In our final discussion, we'll talk about completing the outcome set. What are the considerations for completing your outcome set when you are planning a clinical trial? Once you have your primary outcomes, you need to consider other endpoints: patient-reported outcomes, core outcome sets, quality of life outcomes. Are there biomarkers? Is there imaging? Is there safety? Of course, there should be safety in every clinical trial, but are there safety endpoints specific to your disease and intervention that you need to be aware of? It's also important to note that any of these could actually also be your primary outcome, so adjust as applicable. You very rarely, in fact, would never see a clinical trial that has one sole outcome collected. So you need to think about completing the circle basically for your outcome set. So you do need to focus when you're planning your outcomes. It is tempting with participants in front of you to collect as much information as you can while you have them. After all, you might not have another chance to answer questions about this population again, so can't I get it all now, right? Well, the big answer to that is a resounding no. You need to focus your data collection. Why should I be mindful about it? Participant fatigue is a real thing. Your participants could refuse to complete a procedure. They could refuse to complete the whole visit. They could quit the trial altogether. If you have a participant in your clinic for 8 hours at a time, imagine how daunting that would be to know that they're going to have to give up a whole day to you, or sometimes even 2 days if it involves separate appointments. So just be mindful about all that you're asking them to do and all the information that you're asking them to collect. A large number of clinical trials data is never utilized. So if you can really think about the purpose for collecting that data point, that will have ramifications that you can't even imagine in terms of budget and personnel, costs, how long it takes to run the trial. If you're deciding to collect something like the PROMIS scale or the short health form, and your study is only 6 months long, be very mindful that those do not change quickly. Those measures are very slow to change. And so capturing that data may not prove to be useful. You should also be mindful about your data collection order with your outcomes. You do not want measures of disease progression or fatigue or pain or cognition to be influenced by the time they spent in the clinic. Just think about how tired you are after a full day of work when you go home and you have trouble finding words or you've misplaced your keys. Think about trying to measure someone's cognition after you've already had them in the clinic for 4, 5, or 6 hours. Think about the order of the collection. If you want them to walk, you might want to do the timed walk first rather than after they've been traipsed around a clinical setting. If you want them to do cognition or memory, you may want to think about the other interventions that you have them doing. Utilize your time wisely so that when they check in at the clinic, you have them doing the patient-reported outcomes in the waiting room, or even potentially in an iPad, or they could do them at home. So give them a reminder that they have 2 or 3 days to enter in those patient-reported outcomes outside of the clinic. You want to balance multiple visits with one long visit. So if you do have things like MRIs, laboratory, x-rays, stress tests, you may want them to come in and do those visits in the morning and take a break and come back and do the rest of the clinical visit in the afternoon. Or if they have to travel a long distance, you definitely need to get it in all in one day, so be mindful of that. Or if it's local, then maybe they can spread it over the course of a couple of days. Remember, your participants have lives, they may have jobs, they may have families. You do not want your clinical trial interfering with their outside life so much in that they leave or quit your study. There are existing core outcome sets, or COSs. They have been developed to reduce outcome reporting bias and inconsistency within and across disease populations. Well, this can certainly streamline protocol development and speed up the overall trial. You will not have to develop your own metrics. These are validated outcomes. They are accepted. If you're looking to develop a core outcome set, so if you've done a search and your disease area doesn't have one, but you've noticed over the course of time that people are reporting similar outcomes, but they're not all the same, and that makes it hard to look at the overall evidence of this intervention, there's a process that's been developed by a group called COMET, C-O-M-E-T, and it's basically determine what you want to answer, determine how you want to answer it, and then gain consensus. And the consensus part is really key, and that happens at a couple of times during the process. So you want to start by looking to see if there's an existing COS or one that can be altered or updated to fit your disease. If you're going to develop one or update one, you want to define the scope. Decide if a COS is needed. That may actually take some consensus as well. Develop a COS protocol. So you develop a protocol about what is needed and then who is going to do it and how it's going to be assessed. Once you have your protocol for COS development, you would then determine what to measure. So what existing metrics are out there, what is missing in the field, and then get consensus. Once you've determined what to measure, you need to determine how you're going to measure it. Are there existing measurement instruments? Are there existing definitions? Then you need to have some quality assessment on the instruments and the definitions, and again, get consensus. There are a number of examples of core outcome sets. If you're working in rheumatology, there's OMERACT and EULAR. They're quite similar. One is European. So if you're running a study in rheumatoid arthritis, oftentimes you'll collect all or part of the OMERACT and EULAR components. That allows the study results to be compared to prior and future trials. The PROMIS measures, patient-reported outcome measurement information system. There are a number of PROMIS scales. They're basically multi-composite questionnaires, patient-reported, that are then translated into a T-score, which of course is similar to a standard normal. And that will compare your population to the general population. Some of the PROMIS questions are very interesting, and you might want to use the metric of an individual question more so than the PROMIS scale overall. The overall PROMIS score is slow to change, and it's actually somewhat hard to interpret in terms of disease status, but it does give you an overall idea of how your participants are doing. There is the WHO ICF, or the World Health Organization International Classification of Functioning Disability and Health. And the World Health Organization actually has a number of core outcome sets that you can use, particularly if you're doing public health or broader interventions than just disease interventions that are specific to your one area. If it's something that's a broader scale or a public health scale, the World Health Organization core outcome sets are quite nice. And you can get something even very specific here. There's an Acne Core Outcome Research Network, or ACORN. That's for dermatology and specifically to acne. The one thing that's really important when you're looking at core outcome sets is that they have included, or you do include, participant or patient input in development. When you're doing a clinical trial, the results are only as important as the patients deem them to be. So if an intervention is very arduous, if it's hard to understand the meaningfulness of the outcome, if patients think it doesn't apply to them, then they won't do it, even if it's shown to be beneficial. So it's important to consider the whole picture for your trial. Consider the whole patient. Once they enter your trial, consider the whole participant. Make sure your trial has some measure of each of the following. So a clinical impact, a patient impact, general health description, and safety. Beyond that, make sure you refine your data collection to streamline your trial. It will also reduce costs and save time. Consider the participant time, consider the clinic time, collect information that is generalizable to your disease and the general population if applicable, and only collect what you need. Just consider the time it takes to produce all these analyses, and that usually the budget runs out before analysis are completed, and oftentimes there are data sets that go unutilized for years, if ever. So only collect what you have the intention to use, and that will improve the trial overall.